Good afternoon, ma'am. Good afternoon, friends. So today we will discuss about the new topic, that is cystic fibrosis. So cystic fibrosis is an autosomal recessive multisystem disease which is characterized by altered transport of sodium and chloride ions in and out of the epithelial cells. So the cystic fibrosis is a genetic disorder. So there is an autosomal recessive multisystem. So this cystic fibrosis may affect more than one body system. More than one system are involved in cystic fibrosis. So it is an autosomal recessive multisystem disease characterized by altered transport of sodium and chloride ions in and out of the epithelial cells. So next we can move on to the incidence of cystic fibrosis. The cystic fibrosis was first described in 1938 when the autopsies of young children revealed multiple cysts in the pancreas. And the cystic fibrosis is well studied in the Caucasian population, and there is a low incidence is reported from European countries. Approximately 30,000 children and adults in the US have the cystic fibrosis, and about 10 million Americans who are carriers of cystic fibrosis gene but do not have the disease. So in India, the recessive allele frequency and the heterozygosity for cystic fibrosis, which is very low in India, and also in India, one baby is born with this cystic fibrosis in 14,000 live birth. Only in India, the incidence of cystic fibrosis, that is 1 in 14,000 live birth. Next, we'll move on to the etiology. So etiology, first one is genetic. So in genetic, it is caused by the mutation in the gene for the protein cystic fibrosis transmembrane conductance regulator, that is CFTR, on the chromosome 7. So we have, in definition, we have seen this cystic fibrosis is an autosomal recessive disorder, and this cystic fibrosis gene, which is located on this chromosome 7, so which produces a protein that is called this cystic fibrosis transmembrane conductance regulator. So this cystic fibrosis transmembrane conductance regulator, which is responsible for the regulation of sodium and chloride movement in and out of the epithelial cells. So this CFTR protein, which is mainly present in the epithelial surface of the respiratory system, gastrointestinal tract, and ducts of liver, pancreas, and the biliary system, and also in sweat glands. So this CFTR protein, which is responsible for the regulation of the sodium and chloride movement in and out of the epithelial cells. So when the mutation in the CFTR gene occurs, that become alter the CFTR proteins. So this CFTR protein that we have seen that this CFTR protein localizes on the epithelial surface of these lungs, pancreas, intestine, and other organs. So all these organs which may produce secretions, this mucus and other secretions. Usually these secretions have high water content, but in cystic fibrosis, due to this disturbed or defect in this sodium and chloride movement, the secretions become very low in sodium chloride content. It means there is low in water content. There is low water content in these secretions, and so the secretions become more sticky and thick. These mucus and other secretions become more sticky and very thick. So the mucus become accumulated in the lungs or the ducts of other organs. So that is the main thing happen in this cystic fibrosis, uh, and that is about the CFTR protein. So uh, this mutation in this gene for the protein CFTR on chromosome 7, that is the one of the major cause for cystic fibrosis. Next is family history. Mm, a family history, that is, if both parents are the carriers of this affected gene, there is a 25% chance each offspring will have this disease. So in the next slide we have seen one picture. So here the picture showing that the father and mother are the carriers of cystic fibrosis gene, and the first child who do not have cystic fibrosis, and the second and third child are carriers of the cystic fibrosis gene, and the fourth child the fourth child have the cystic fibrosis. It means if there is a 25% of chance in each offspring will have the disease if the both parents are carriers of the affected gene. Next is race. So it occurs in all races, and it is most common in white people of northern European ancestry. So next we will move on to the pathophysiology. So in pathophysiology, the cystic fibrosis is primarily affect the lungs, gastrointestinal tract, and reproductive tract. So in in etiology, we have seen that the CFTR protein is responsible for the this regulation of the sodium and chloride movement. So this protein is mainly seen in the epithelial cells of these lungs, GIT, and reproductive tract and sweat glands. So in pathophysiology, if there is a defect, that is a CFTR gene defect occurs, that leads to reduced quantity and function of the CFTR protein. So that leads to the defective ion transport. When there is a reduced CFTR protein, that leads to defective ion, that is sodium and chloride transport, which leads to airway surface liquid depletion. So when the defect in ion transport occurs, the liquid become the secretions become thick and sticky, that is the airway surface liquid depletion occurs. So that leads to the defective mucociliary clearance. So in respiratory system, both the upper respiratory tract and lower respiratory tract are involved. So one of the major feature of this cystic fibrosis, that is the involvement of the involvement and which this disease affect the airways. So it usually initially this affect the smaller airways, and later when the disease is progress and it become affected to the larger airways, and finally leads to the destruction of this lung tissue. So in here we have seen there is a defective mucociliary clearance. So when there is a the mucus become tenacious and become dehydrated due to the defect in chloride secretion. So there is an excess sodium absorption also occurs, and the ciliary motility also decreases. So the mucus become plugs into the airways. So the bronchioles, which become obstructed with this thick mucus, so that leading to the scarring of these airways. So when this mucus accumulated or that become obstructed the within the bronchioles, that leads to scarring and also air trapping, and also the hyperinflation of the lungs also occurs. So that is happening next stage, or the next step, that is when there is a defective mucociliary clearance, there is a mucus obstruction, infection and inflammation occurs. So the mucus obstruction, we have seen this we have discussed about the obstruction. The mucus obstruction will lead to the scarring of airways, air trapping and hyperinflation of the lung occurs. Next is infection. So another characteristic feature of the cystic fibrosis is chronic airway infection. So the most common organism which cause the respiratory infection are the Staphylococcus aureus, Haemophilus influenzae and Pseudomonas aeruginosa. So these are the common organism which causing the respiratory infection. In this, the Pseudomonas is most common organism causing infection in adult. And usually this organism is cultured from the sputum, from the patient's sputum. And so the pulmonary inflammation. Next is inflammation. So the pulmonary inflammation is which is usually associated with this chronic infection. So when there is a pulmonary inflammation occurs, so that will decrease the respiratory function, and also there is a release of inflammatory mediators like interleukin, oxidants, protease also released, so that may further causing the lung inflammation. So initially the lung disorders are present as the chronic bronchiolitis and bronchitis. So when the lung disorders become progressive for months or years, so that results in changes in the bronchial wall. So if the changes are persist for a longer period, the pulmonary vascular remodeling occurs and pulmonary hypertension occurs, and finally it results in cor pulmonale. So that is the progression of disease in cystic fibrosis in respiratory system. That is when there is a CFTR gene defect occurs, there is a reduced quantity or function of this CFTR protein. So when the CFTR protein become not functioning properly, that leads to defective in ion transport, that is sodium and chloride ion transport become disturbed. That leads to the airway surface liquid depletion, that is the secretion become more thick and sticky or tenacious, which leads to defective mucociliary clearance. So when this ciliary action become reduced, so this mucus become or the secretion become accumulate within the airways or the bronchioles. So that leads to the scarring, air trapping and hyperinflation also occurs. And also the main changes happens in lungs, that is one is mucus obstruction, infection and inflammation. In infection, the infection is another characteristic feature of cystic fibrosis. Mainly the chronic airway infection are caused by the organism like Staphylococcus aureus, Haemophilus influenzae and Pseudomonas aeruginosa. The Pseudomonas is the most common organism that organism in adult for causing this airway infection. And usually this organism is cultured from patient's sputum. So then and also the inflammation, that is pulmonary inflammation in occurs in period, there is a release of inflammatory mediators, and finally, if the changes may progress or persist for longer period, there is a changes in bronchial wall, so that may leads to the pulmonary vascular remodeling and pulmonary hypertension and core pulmonary results. So that leads to the end stage lung disease. These pathophysiological changes may result in permanent damage to the lungs. So that is the main pathophysiological changes occur in lungs. Next, there is pancreatic involvement. So pancreatic involvement, there is a mucus plugging of the pancreatic exocrine ducts. So that leads to the atrophy of glands and a progressive fibrotic cyst formation occurs, which leads to the pancreatic insufficiency, and pancreas exocrine function may become completely lost, so which leads to the fat and protein malabsorption occurs. So in pancreas, the changes due to the cystic fibrosis is mainly that there is a mucus when this calcium and chloride movement become affected, so the mucus plugging of the pancreatic exocrine ducts, so that leads to the atrophy of glands and progressive fibrotic cyst formation, so which leads to the pancreatic insufficiency, and pancreas exocrine function may be completely lost, so which leads to the fat and protein malabsorption occurs, that ultimately leads to the clinical different patient may show the clinical manifestations. Next is this cystic fibrosis related diabetes mellitus. So this CFRD, that is cystic fibrosis related diabetes mellitus, occurs due to, or it is caused by the underdevelopment of pancreatic islet cells, that is from the uterus. So from the uterine within the uterus, there is a underdevelopment of this pancreatic islets of Langerhans, and also there is a destruction of islet cells over the individual lifetime. So all this leads to the development of cystic fibrosis related diabetes mellitus. And next is other GI, that is gastrointestinal system involvement, includes there is a trypsin, chymotrypsin, lipase and amylase, which do not reach into the small intestine, so that may disturb the small intestine, and the digestion become impaired, and the meconium ileus often occurs in children. If there is, and next is the distal intestinal obstruction syndrome. So the distal intestinal obstruction syndrome, which results from the intermittent obstruction commonly occurring in the terminal ileum at the point of ileocecal junction. Next is biliary cirrhosis may occur in some patients, and the gallstones may develop in some cases. So next in sweat gland involvement, this that is there is a high concentration of sodium and chloride in sweats of patient with this cystic fibrosis, that results from the decreased chloride reabsorption and within the sweat duct. So and the saliva, and which also contain the excess sodium and chloride. So that is the different pathophysiological changes occurs in different system. So we have, in definition, we have seen that this is a multi-system disorder. So we have seen the pathophysiological changes in the lungs and pancreatic involvement and GI, gastrointestinal system involvement, and sweat gland. In sweat gland, there is a high concentration of sodium and chloride in the sweat of the patient with the CF, which is results from there is a decreased chloride reabsorption from the sweat duct. Next is the clinical features. Clinical features of that is cystic fibrosis. The first signs and symptoms which is typically occur in children, but some patients do not diagnosed until they become adults. The respiratory manifestations mainly include that is in other there is a recurrent pulmonary infection. In pathophysiology, we have seen there is a pulmonary. That is one of the characteristic feature of this cystic fibrosis is chronic airway infection. So recurrent pulmonary infection with this Haemophilus influenza, Staphylococcus aureus, Pseudomonas aeruginosa will occur in cystic fibrosis, and cough. It become dry to productive cough, and wheezing crackles may present on auscultation, dyspnea present, and barrel shaped chest, and clubbing of fingers and toes, and nasal polyps and parasinusitis. And this nasal polyp and parasinusitis, which is due to the upper respiratory tract manifestation of this cystic fibrosis. And in later stage, there is a progressive COPD, that is chronic obstructive pulmonary disease, may occur. A 10% of drop in this forced expiratory volume, that is FEV, is a sign of acute exacerbation or worsening of this lung disease. In mild form cystic fibrosis, there is a slightly decrease in this functional expiratory volume. So forced expiratory volume. The forced expiratory volume means the amount of air exhaled. It may be measured during first second or third second of the forced breath. So if there is a slight decrease in FE1, that is 70 to 90%, it indicates mild form of cystic fibrosis. If there is a moderate CF, it means there is an FE1 of 40% to 69%. In severe form of cystic fibrosis, there is a life-threatening pulmonary disease with this forced expiratory volume in 1 second, that is less than 40%. So these all are the clinical features in the respiratory system. Next we can see the gastrointestinal manifestations. First one, that is meconium ileus, which is present in neonates, and next is failure to thrive and failure to gain weight. So due to this fat malabsorption or fat or protein malabsorption, which may result in this failure to grow and to failure to gain weight. Next is abdominal distension. So abdominal distension, the distal intestinal obstruction syndrome. The patient may have a right lower quadrant pain and also have a loss of appetite, nausea, vomiting, and if sometimes may be a palpable mass. Next is vomiting, dehydration, electrolyte imbalance may occur. Next is steatorrhea. So steatorrhea, so due to the malabsorption of this fat, protein, and fat soluble vitamins, so that leads to the fat malabsorption, so which results in this steatorrhea. Next is development of rectal prolapse and pancreatitis, gallstones. And if uh, the patient develops this, that we have already seen, that is distal intestinal obstructive syndrome, patient may have a lower quadrant pain, lower quadrant abdominal pain, loss of appetite, nausea, emesis, and also palpable mass. Next is manifestations related to the reproductive system. So in the reproductive system, both males and these females have delayed puberty. In men, the vas differences fail to develop within the utero, so there is a defective sperm transport. So that leads to sterility in male. In women, there is a difficulty in conceiving and also cervical mucus thickening, and during exacerbation, the menstrual irregularities and secondary amenorrhea, which is common in women. So these all are the main manifestations related to reproductive system. That is, both male and females have delayed puberty. In men, vas differences fail to develop in utero, and also there is a defect in sperm transport. So that results in sterility in men, and in women there is a difficulty in conceiving and cervical mucus thickening occurs, and also during exacerbation there is menstrual irregularities and secondary amenorrhea are common. um, Next is other manifestations. So the other manifestations include osteopenia and osteoporosis. This osteopenia and osteoporosis, these are disorders related to malnutrition and malabsorption of vitamin D, and also due to the insufficient testosterone level, and also due to the chronically elevated inflammatory cytokine. Next is thin extremities and sallow skin and wasted buttocks. Next is hyperglycemia. So hyperglycemia, that leads to glucosuria, polyuria, and weight loss. Next is hypoproteinemia and anemia, and bleeding disorders, hyponatremia and heat prostration. And next is kyphosis. So these all are the other manifestations of cystic fibrosis. Next, we can see the complications of cystic fibrosis. So complications, that is cystic fibrosis related diabetes. So this cystic fibrosis related diabetes, CFRD, we have already seen that there is due to the underdevelopment of islet cells within the utero. That leads to the this cystic fibrosis related diabetes mellitus. Next is bone disease. Next is sinus disease and liver disease. Next is pneumothorax and core pulmonary and respiratory failure. And one more complication which is related to this cystic fibrosis, that is hemoptysis. So hemoptysis, which is caused by the proliferation of capillaries in response to chronic infection. So during exacerbations, there is an erosion of this capillaries occurs, and this hemoptysis may results. So which is a rare, relatively uncommon complication of cystic fibrosis, and when it occurs, it is a life-threatening complication also. Next is about the diagnostics test of cystic fibrosis. So the diagnosis test, which is mainly include this first one is sweat chloride test. So the sweat chloride test is considered as a gold standard test for the diagnosis of cystic fibrosis and is performed within the pilocarpine ionotrophoresis method. So this pilocarpine, which is placed on the skin and is carried out by a small electric current to stimulate the sweat production. So this part of the process which takes about 5 minutes, and the patient feels a slight tingling or warmth. The sweat is collected on a filter paper or gauze and then analyzed for sweat chloride concentration. The test usually takes approximately 1 hour. The sweat chloride value, which is above 60 millimole per liter, which is considered as the positive for the diagnosis of cystic fibrosis. And the second sweat chloride test, which is also obtained at the same time, that is one test from each arm. So the second test is done, which is mainly to confirm the diagnosis. For that, we are doing the second sweat chloride test. So this sweat chloride test is the most important or the gold standard diagnosis test for the cystic fibrosis. Next is measurement of trypsin concentration in duodenal secretion. Next is analysis of digestive enzyme. Next is chest X-ray. So this chest X-ray may be normal initially, but it may become in later it shows areas of infection, overinflection, or bronchial thickening and plugging of these secretions. So next is sinus radiograph or CT, that is computer tomography. The sinus radiography that shows mucus plugging within the sinuses. Next is for this analysis of stool. So the stool analysis, which is mainly done for steatorrhea, to confirm the steatorrhea. Next is meconium strip test for stool. So the meconium strip test for stool, which include the presence of lactase and protein content, used for a screening purpose. Next is so this in next slide there is the picture. This picture showing the sweat chloride test, how to perform the sweat chloride test. So the next diagnostic test is the sputum or throat culture. So sputum or throat culture, which is done to rule out the infection. Next is pulmonary function test. So the pulmonary function test, which shows there is a decreased vital capacity and flow rate, and also there is a increased residual volume and increased total lung capacity. Next is prenatal diagnostic test. So the prenatal diagnosis test, which is genetic screening for is done for genetic screening for families affected with the cystic fibrosis disease. So it mainly includes this chorionic villus sampling, which is done approximately at 12 weeks of gestation. Next is neonatal screening. Neonatal screening, that is for immunoreactive trypsinogen may identify so through the neonatal screening. So these are the most important diagnostic tests used in cystic fibrosis. Sweat chloride test is the most important and gold standard diagnostic test. Next is measurement of trypsin concentration and duodenal secretions, analysis of digestive enzyme, chest X-ray, sinus radiography, analysis of stool, meconium strip test for stool, sputum or throat culture, pulmonary function test, prenatal diagnostics test, neonatal screening. Next is about the management of this cystic fibrosis. So management management is mainly involved. There is an interprofessional team should be involved in care of patient with the cystic fibrosis. The team should include nurse, physician, respiratory therapist, physical therapist, dietitian, social worker, and often a nurse practitioner. So the management of pulmonary problem in cystic fibrosis, which mainly include the relieving airway obstruction and controlling the infection. So the infection is controlled by administration of antibiotic medication. So the antibiotic uh, medication or the administration of antibiotic is the most important thing in controlling the infection. The standard treatment of infection include the antibiotic therapy along with the airway clearance techniques. Usually the long course of these antibiotics which are useful and a prolonged high dose of antibiotic therapy may be recommended or which may be necessary for these patients because these many drugs which are abnormally metabolized or rapidly excreted in patient with cystic fibrosis. So there is a long course of antibiotics and prolonged high dose therapy may be needed in this patient. And in Pseudomonas infection, which are the common infection in patients with the cystic fibrosis, so which are difficult to treat because the long-term cause of this long-term use of this antibiotics that may result that is in later this organism may develops a resistance to the antibiotic. So that is a major problem in treating with antibiotics in Pseudomonas infection. Next is the aerosolized tobramycin, which is the most commonly used drug, which is given to patients who are chronically infected with this Pseudomonas organism, or which is this aerosolized tobramycin is the most commonly used drug in Pseudomonas infection. And also this aerosolized tobramycin is also given in every other month and twice a day. So, and the drugs which is commonly used for mild exacerbation, which are usually oral antibiotics. So oral antibiotics mainly include semi-synthetic penicillins, trimethoprim, and sulfamethoxazole or oral quinolones. So the quinolones, these oral quinolones which are used judiciously because of the rapid development of resistance to these strains. Next is azithromycin. Azithromycin is another drug which is used for long-term use, that is more than 6 months. So that also decreases the pulmonary exacerbation and also acts as and it also has an anti-inflammatory property. So the azithromycin is used for a long-term use. So, and also the usually the treatment of antibiotic therapy which is used in cystic fibrosis, which is a combination of two drugs which have different mechanism of action. So the usual treatment of two antibiotics are cephalosporin and aminoglycoside. So there is a combination of different mechanism of action. Medications are used in treatment of cystic fibrosis. Next is bronchodilators. Bronchodilators that used to decrease the airway obstruction and assist in mucociliary clearance. Next is use of aerosols, expectorants, and mucolytic agents to decrease the viscosity of the secretions. So this next is inhaled steroid, which is for airway hyperactivity. Inhaled steroids for airway hyperactivity. Next is agents that some drugs that degrade the DNA, that is deoxyribonucleic acid in cystic fibrosis sputum, that increases the airflow. So the abnormal viscosity of the CF cystic fibrosis secretions, which is increased by concentrated deoxyribonucleic acid from the neutrophils involved in chronic infection. So the one drug, that is dorsenase alpha, which is an agent that degrades the DNA in cystic fibrosis sputum and thereby increasing the airflow and reducing the number of acute pulmonary exacerbations. Next is inhaled hypertonic saline. The inhaled hypertonic saline, that 7% is effective in clearing mucus, and this also decreases the frequency of exacerbation. Next is evac after. Evac after, which is used to treat patients who have mutation in the cystic fibrosis transmembrane reductase gene. Next is airway clearance techniques. Airway clearance techniques mainly include that is chest physiotherapy, coughing and deep breathing exercise, autogenic drainage, half coughing and pursed lip breathing. This autogenic drainage means breathing at various lung volume to move or evacuate the mucus. That is autogenic drainage. High frequency chest compression means these are externally applied device which provide oxygenation to the chest and resulting in the release of mucus from the airway wall. Next is oxygen therapy. The patient with co-permanent or hypoxemia may require oxygen therapy. Next is patient with large pneumothorax, which may require chest drainage. And next is sclerosing of the pleural space. If the pneumothorax is persist, or when there is a recurrent pneumothorax occurs, that is sclerosing of pleural space, or partial pleural stripping and pleural ablation may be needed in recurrent pneumothorax. Next is bronchial artery embolization for massive hemoptysis. So in complication we have seen the hemoptysis is one of the rare complication of the cystic fibrosis. So, and also it is a life-threatening emergency. So in case of massive hemoptysis, bronchial artery embolization may be needed. Next is lung transplantation. This cystic fibrosis is considered as a indication for lung transplantation. Next is promoting adequate nutrition. So adequate nutrition, so in clinical manifestation and also this, so we have seen that this is a multi-system disorder involving gastrointestinal tract, biliary system, so and pancreatic involvement also. So there are many nutritional deficiencies may occur. So nutrition management is very important in patient with the cystic fibrosis. We have to promoting adequate nutrition. So the pancreatic insufficiency may managed with the pancreatic enzyme replacement of lipase, protease, amylase, and also adequate intake of this fat, calories, proteins, vitamins, and fat soluble vitamins which should be supplemented in case of fat malabsorption. That is fat soluble vitamins are vitamin A, D, E, K. These are the fat soluble vitamins which must be supplemented, and also added dietary salt which is indicated in case of excessive sweating. Next is hyperglycemia. In a case of hyperglycemia, that is it may require insulin treatment. Next is distal intestinal obstruction syndrome. So in case of distal intestinal obstruction with complete bowel obstruction, it may need gastric decompression, and if the this distal intestinal obstructive syndrome which does not resolve with the medical treatment, surgery may be needed, and also we have to monitor for the bowel patterns of the patient. Next is aerobic exercise program. So progressive aerobic exercise program should be recommended. And gene therapy. So gene therapy is considered as a novel, as a new therapy in cystic fibrosis. Next is enhancing self-esteem and body image. So in case of children, that is, if the child is diagnosed with the cystic fibrosis, so we have to encourage the child, and we explain the procedure and about the therapies in easily understandable manner, and also enhancing the family process, encouraging the parents in treatment, and also explain about the disease condition in simple manner, and also family education and health maintenance. So we have to give health education regarding diet, exercise in cystic fibrosis. Next is nursing diagnosis of cystic fibrosis. So nursing diagnosis mainly include ineffective airway clearance related to thick bronchial mucus and weakness and fatigue. Next is ineffective breathing pattern related to bronchoconstriction and airway obstruction. Next is impaired gas exchange related to recurring lung infection. Next, that is imbalanced nutrition status, less than body requirement related to dietary intolerance, intestinal gas and altered pancreatic enzyme production. Next is ineffective coping related to multiple life stresses such as decreased life expectancy and cost of treatment. Next is about the prognosis. So the severity and progression of this disease, which may vary with early diagnosis. So the severity and progression of this disease may vary with early diagnosis and improvement of therapy. And the prognosis of patient with the cystic fibrosis, which has significantly improved. The median expected survival was 16 years in 1917, but it has increased to more than 41 years. So this is about the prognosis of cystic fibrosis. So this is all about. So till now we have discussed about the cystic fibrosis definition, etiological factors, and pathophysiology, clinical manifestations, diagnostic measures, and management. So thank you, ma'am. Thank you all.